Okay, you guys still with me? Our last topic that we're going to touch on is leukocytosis. And I'd like to take just a minute here to sort of take a step back and think about when we see a high white cell count. And I'm not just talking like your average little mild, maybe a moderate increase in white cells. I'm talking about a leukocytosis. So here's the deal with our analyzers. They're really good at doing reliable differentials when our patients are healthy and our cells have their normal morphology. So they're really good at shuffling them into the right categories. When they don't do so well is when we have cells that shouldn't be there, or we have cells that are undergoing morphologic changes, like our neutrophils when they become toxic, when there's massive inflammation going on. What I think about being able to identify a mature neutrophil where that becomes particularly helpful is when you're looking at your blood film and thinking to yourself, is this white cell count really that increased? And is this mostly neutrophils or is this mostly something else? So when we look at this, and the reason I do that particular distinction of is this mostly neutrophils or is it mostly something else, is that it's going to send us down two different diagnostic pathways, I think, as well as adjust our conversations with our owners. If we have a sample that has a high white cell count and we put eyeballs on that blood film and we're just scanning around going, yep, there's a lot of white cells here, and yep, they're mostly neutrophils, what comes to mind is inflammation. And we're going to be moving down a slightly different track with our patients, trying to rule out inflammatory disease, or at least a starting point there. If we look at that blood film and we're like, there's a lot of cells here, a lot of nucleated cells here, and they're not all neutrophils. There's a lot of somebody else here. You're definitely going to be having a slightly different conversation with your owner. Like, there's some kind of fishy cells on here. We're going to be thinking about inflammation, but I really want to get a path review on this particular slide. So what can we do to move our diagnostics along a little bit faster by using a blood film in these cases? And what I would encourage you to do is to start getting comfortable with what a neutrophil looks like. Neutrophil. These cells, they're round cells, okay, and they've got neutral cytoplasm. They should be pretty close to the background of your smear, at least in healthy animals. They've got pale pink granules, which you may or may not see. They're not like eosinophils that are like, whoa, smack you in the face, red orange huge granules. They're very more subtle, and they've got this nice segmented nucleus that is really condensed with condensed nuclear chromatin on it. One of the things, by being able to identify a neutrophil and say, hey, that's what the majority of this population is here, that allows us to say, well, we're going to at least start the hunt for inflammation. And we're gonna put that up higher on the list. We're still gonna be sending that CBC off for confirmation and a second opinion and make sure that we haven't missed anything. But at least you can come back to the client and say, hey, I looked at this under a blood film and it's almost all neutrophils. When we see this, our concern more is that there's something inflammatory going on with our patient rather than necessarily a leukemia. When we have an inflammatory response, the first thing that happens is our peripheral neutrophils move to that area and attack whatever needs attacking. If that continues and if that inflammation is severe enough cytokines are produced. I said it, cytokines. Enough cytokines are produced that they go up to the bone marrow and stimulate bone marrow production. Okay, the first thing that happens is like any storage pools that we have get dumped out first because the bone marrow is pretty smart. It keeps a bunch of spare mature neutrophils up there just in case of emergency. They're the first thing to go out. Out into circulation they go. Cytokines will stimulate the early parts of proliferation and drive the bone marrow to speed up its response. So like hurry up, we need more. And it will start releasing neutrophils earlier and at younger stages. So we get two things that end up coming out into circulation. One, we get banned neutrophils or even metamyelocytes. And in really severe forms, it like can go back to earlier precursors even. And then the second thing that happens is that we end up with toxic change. And toxic change is basically what happens when the bone marrow doesn't have enough time to make everything pretty. It's pretty much good enough, get out there, okay? So what are the big features of toxic change? Just a quick review off our list. Dolly bodies, increase in numbers of Dolly bodies, remembering that cats can have some normally. Basophilia, so that cytoplasm starts turning a little more blue. All the RNA in the cells are picking up that blue stain. So they start turning a little more blue, and we may start seeing vacuoles on them, and they kind of look like foamy, dish soap vacuolation to these neutrophils. So for example, I have one here that looks fairly toxic. We can see that this guy has pretty basophilia, some vacuolation. You may or may not see the Dolly bodies if it's severe enough in these guys. Just as a side note, any toxic change in horses is significant. Horses as a whole tend to have really nice, healthy neutrophils. And if we see toxic change in them, it's alarming. So anything, even like subtle Dolly body development in those. The thing with toxic neutrophils is that if the inflammation is severe enough and it's been going on long enough, it can be really hard to distinguish the neutrophils, especially ones that are like bands that having that C shape to them, or even metamyelocytes. It can be really difficult to distinguish them from monocytes. And that's something that takes a lot of practice and looking at a gazillion blood films to hone that particular skill. Okay, so if it's really severe inflammation, you're looking at it, you're just not sure. You're going to be sending out to a pathologist and waiting for that path report getting back. In most cases of those cases, you're going to have other evidence of inflammation that's going to be driving your diagnostic pathway down that route. Neutrophilias or even neutropenias, especially in some of our larger animals. Degenerative left shifts where there's more of the youngsters out there than the mature ones, very sick patient in front of you, febrile, all the signs of inflammation. So if you're looking at that blood film and you're like, God, these guys look really sick, it supports your diagnosis of inflammation. If inflammation has been going on long enough and the bone marrow has had time to respond and has upregulated to meet the peripheral demands, we will start seeing what we call a leukemoid response. And why leukemoid? Leukemoid says it's like leukemia-like. These are neutrophil counts that are starting to push 70, 80, 90, 100,000. It indicates that there's been inflammation cooking somewhere for some time. The classic example of this is canine pyometra, especially closed ones, where we've essentially have this trapped sac of pus that has been recruiting neutrophils for quite some time. And in these particular cases, if it's been cooking long enough, the bone marrow has been responding and we start getting these really high white cell counts. Now we can have pyometras that haven't been cooking long enough to reach that leukemoid response, but it's sort of one of the classic examples that we will give. The other time I have seen this sort of thing from an inflammatory response has been in immune-mediated hemolytic anemia. And not your classic ones that come in super sick with kind of an acute onset. I'm talking about the ones that are these kind of low-grade IMHs that have been smoldering for a while, really been cooking. I've seen some impressive white cell counts with those as well. So one of the first things that we think of when we get these leukemoid responses, and they start moving up there, even though we're using the term leukemoid, is that we want to make sure that there's no inflammation going on in this patient. That's the first thing that we're going to be ruling out with these guys. We back into weird stuff where we get really high levels of white cell counts and mature neutrophils, and the weird disease being a chronic granulocytic leukemia, that's those neutrophils. How often do we see those? Like hardly ever. You may catch them in practice from time to time, but it's very much a diagnosis of exclusion. You have to like rule out all inflammation. So before we give any patient cancer, let's make sure it's not inflammation. What about when neutrophils look like bands or even metamyelocytes, and that's all you see on your blood film, but you've got a healthy animal? So once in a blue moon, you may come across a patient with Pelger-Hewitt anomaly, and this is a genetic defect that basically prevents neutrophils from fully segmenting. And what you will see on your blood film is bands and maybe metamyelocytes. The interesting part of this whole Pelger-Hewitt thing is that the eosinophils, as well as the basophils, though we don't really see them out there, but the eosinophils will also have poorly segmented nuclei. Our classical breed for Pelger-Hewitt is the Australian Shepherd in dogs. With that said, it can happen across many breeds. In dogs, I've seen it in cats. It is definitely in people. So it can show up. It's something to sort of keep in the back of your cranium, and don't be fooled. Don't be fooled. These are nice, mature, healthy looking neutrophils. Their chromatin's super condensed like they would be in segmented neutrophils that are nice and mature. They just haven't segmented. So this patient doesn't have massive inflammation. They'll present healthy. You'll be like, piece is not adding up. And that's when we sort of think, is this Pelger-Hewitt? When you have one of these cases, send it off with a detailed history for a path review. We're trained to look at this stuff, so we can help. So what if it's not neutrophils? Are they another white cell? Like fairly normal white cell. For example, eosinophilia. Thinking about parasitism, skin disease, pulmonary disease, GI disease, all that fun stuff that goes along with eosinophils. Rarely something like paraneoplastic. Classically, mast cell tumors, lymphomas, occasional carcinomas. Another thing these guys could be are nucleated red blood cells. Typically, we see these guys out in circulation when there's a regenerative anemia present. So look at the cells around. Polychromatophils. Does it look regenerative? Is this patient massively anemic, et cetera, et cetera? That's sort of the first thought for those. And we call that an appropriate metarubicytosis, an appropriate response when we expect to see it. They can be out there for other reasons. I see it with like heat stroke. We see it with lead toxicity, sometimes splenic contraction, all sorts of different things that can potentially cause it. Also including but not limited to our bone marrow diseases, bone marrow dysplasia, and all sorts of stuff. So just like anything, check in with your clinical pathologist and make sure that it's appropriate. Are they blasts? You've got those round cells, round nuclei looking at you, okay? That's when you're going to be definitely sending it off to a clinical pathologist to review and confirm. There's probably going to need to be additional diagnostic testing to figure out what they are. Provide a detailed history in case it's a stage 5 lymphoma versus a leukemia. Okay, so not neutrophils. Is it recognizable and you're comfortable going forward? Go get them, tiger. If it's not recognizable, make sure you use us. Ask for a path review. And send us as much like history and detail as you can alongside with that CBC. The more knowledge we have of what you're seeing in your case, the farther we can take our interpretation and the more we can help you. So there we go. Let's wrap up our white blood cells. What have we reviewed today? So we've reviewed neutrophil morphology. We've talked about bands and metamyelocytes. And we've talked about how when inflammation is more acute and driving that white blood cell response, that they can sometimes have evidence of toxic change, increase in Dully bodies, basophilia, foamy cytoplasm. Patient not sick and looking inflammatory, but has a bunch of youngsters out in circulation. Think about Pelger-Hewitt, send it off to your clinical pathologist with a detailed history. What about long-standing inflammation where you start getting marked neutrophilias that start approaching that leukemoid range? You want to make sure you're ruling out all things inflammation before landing on something like a chronic granulocytic leukemia, which is a diagnosis of exclusion. Make sure you utilize your clinical pathologist, send off a detailed history. Okay, here we are on the other side of all of this. Let's sort of review our journey, where we've been today. So the first thing, and what I hope is going through your mind, is some enthusiasm towards utilizing blood films. And the first thing we need to do that is to train ourselves how to make them. So throw yourself a blood film training party. Woohoo! Blood film party. We've made friends once again with platelets in terms of looking for clumps and how to do a quick and dirty estimate as you're looking, trying to evaluate thrombocytopenia. We have reviewed our erythrocytes and what we look for in a regenerative anemia, including our polychromatophils. And then we touched on some of our hot topics, which are spheres, schistocytes, as well as our Heinz bodies, eccentrocytes, oxidative change. In white cells, our theme was to neutrophil or not to neutrophil, and how to sort of approach it, your discussions with clients, and going forward from there. Stuff that you're going to need on that daily basis to intervene more quickly. Don't forget to use us. That's what we're here for, and we are honored to be part of your team. It's my hope that you have found this review helpful and practical, and that you can start implementing some of these things and getting your skills up. So I appreciate you taking this journey with me, and I am looking forward to your questions and your feedback. All right. Thanks, guys. You know you're a clinical pathologist when you start to personally identify with certain red cell morphologies.